Hello, everyone. Welcome to today's edition of pathologycast. Today is November 19, 2024, and it's a Tuesday. I'm Rifat Mannan in California. So today we are welcoming Dr. James Lewis, who is Senior Associate Consultant and Center of Excellence at Mayo Clinic, Arizona. And he's going to give a talk on blue cell tumors of the sinonasal tract, which he says that it's the nose alarm. And we are very excited to have Dr. Lewis with us today. And thank you so much for joining us, Dr. Lewis. Over to you. Thank you.
Thank you so much. Thank you, Dr. Manan. I've been a big fan of Pathcast for a long time, and excited to do one myself. And this is a topic that I'm really passionate about, and that's blue cell tumors of the sinonasal tract. I kind of call this area the nose alarm, and we'll talk about why as we go through these. So I'm going to turn off my video, and here we go. Okay. So we've all been there, right? We get this small biopsy of blue tumor at sinonasal tract, and it's a specimen where we look at it and we think, oh my gosh, that could be just about anything. How am I going to figure this out? This looks really difficult. And so we get kind of exasperated, there's a lot to think about. There's a lot of tests we could utilize and information that kind of comes into play. It's a bit stressful. And I actually like to channel Pepper Daner, who was a very senior surgical pathologist at Washington University, who I learned a lot about surgical pathology from. And he loved to call these shaggy dog tumors. And why do we call these shaggy dog tumors? Well, because they kind of look the same from every different direction. Every way you look at them, they look kind of like the same kind of an amorphous blob. But anyway, to compound the difficulty is we have a complex anatomy. So the sinonasal tract has a lot of different compartments, and it's near prime real estate. So it's near the brain, it's near the eye, the globe, the orbit, the oral cavity, the facial skin, the pituitary, even if big enough, can get back near the spinal cord. So it's kind of prime real estate, and this kind of gruesome sagittal section of cadaver kind of shows it well. You can see just how close the sinonasal tract is to so many critical structures. You get an idea there as well, particularly the eyeballs, the globes. Now, this is a complex and difficult topic. It's kind of a classic topic in head and neck pathology. And a lot has been written, a lot of really excellent writing about this topic. It's a deep one with a lot to it. And I recommend here's 3 sort of excellent review articles on the topic. What happens a little bit with them, though, is you get really big tables like this. You might get big decision trees, and it can be just kind of a bit overwhelming because there's so much to think about. And several years ago, I was kind of driving back to an interview at an institution several years ago, and suddenly kind of had this epiphany about an acronym that could capture a lot of the different entities in the differential diagnosis of this. And that's when I came up with this kind of acronym that I call the nose alarm. Okay. And I find this particularly helpful personally because it is a pretty extensive list of the tumors in the differential diagnosis for blue cell tumors of the sinonasal tract. Lester Thompson, who's an amazing head and neck pathologist, has kind of Mr. Sleep or Mrs. Sleeps, which is his version. But I always liked this one because I never liked the fact that it didn't have the word nose in it or something nasal, something related to the actual site. So here's the nose alarm: nut carcinoma, olfactory neuroblastoma, olfactory carcinoma, squamous cell carcinoma, small cell carcinoma, sinonasal undifferentiated carcinoma, the SMART deficient sinonasal carcinomas, and then the E is Ewing sarcoma, A for adenoid cystic carcinoma, L for lymphoma, large cell neuroendocrine carcinoma, and even lymphoepithelial carcinoma, AR for alveolar rhabdomyosarcoma, and finally melanoma has several, M has several things in it, including melanoma, multiphenotypic HEV-associated carcinoma, and never forget metastasis. Okay, every once in a while, that's the tumor that's presenting in the sinonasal tract, and you don't want to miss it. Now, several years ago, I did a course at the USCAP with Justin Bishop and Rebecca Chernock, and Justin Bishop presented on sinonasal blue cell tumors. He's a remarkable pathologist with a lot of publications and a lot of writing about this. And he kind of got me into the idea that you could have a basic immunostain panel. You know, if nothing else, if you knew nothing else about the blue cell tumor, you threw this panel at it, it would be a very good starting point that covers a lot of the main entities. So there's 8 immunostains in my basic panel. Okay, a broad cytokeratin, P40, Desmond, synaptophysin, CD99, SOX10, a CD45, and I have recently put in INI1, which is the protein for SMARCB1, kind of in my first line panel. And then there's a lot of potential additional clarifying stains, okay? HPV testing, skeletal muscle specific markers, more specific neuroendocrine markers, more melanoma markers, NUT, IDH1 and 2, EBER. So a lot of other things that are in a second round potential use in these patients. And then, of course, FISH testing or even fusion panel testing as needed in certain entities, okay? And so those are kind of the tools that we have for a diagnosis. And if you think about like very old school pathology where it's just straight H&E, we're not doing that, obviously. But there's also the other side of it where you just say, well, look, you know, I'm not even going to use much. It's a blue cell tumor. I'm just going to throw a whole bunch of immunostains at it. And so it's kind of like a slider bar, you know, and you kind of think, you know, where on this slider bar should I be? How much should I go with H&E? How much should I go with a bunch of immunostains? And I think it really is entity dependent. But the approach today, I think, that I have hopefully will give you a better idea of where to be on that slider bar. Okay, so I kind of have a stepwise approach. The first thing I always do is review the H&E slides, right? And I try to do it with no additional information. And then, of course, critically, we've got to then review the clinical history and the imaging, anything else from the patient's story that can help us, review prior specimens if need be. And then at that point, I order my kind of basic first round panel that is modified by morphologic clues, okay? And so based on those clues, I may remove select tests from the initial panel, and I may add certain things in there, sometimes in situ hybridization or immunohistochemical tests up front, okay? And then once those come back, if they don't totally clarify it or they give me a better direction to go, then order additional immunohistochemistry in situ hybridization or even molecular testing as needed. And that's kind of how I do it, okay? And so there's a lot of clues off the H&E slides and the clinical history and the imaging, okay? And I thought it'd be instructive to just really go through a lot of those clues, the clues that I kind of use and that others use to try to suss this out. Now, before we do that, I don't want you to kind of get the blues, all right? At first glance, these tumors look very similar, okay? And you say, well, my goodness, they all just look the same. So don't get depressed about this if you start to have that feeling. You just need to hold in there and look for some of the subtle clues that are on those slides. And there are a lot of them, and we're going to just go through a lot of them. So let's start. We'll work our way through the nose alarm. So nut carcinoma, okay? Nut carcinoma is a translocation-driven carcinoma. Occasionally happens in the sinonasal tract. And as a translocation-driven tumor, it tends to have this monotony, okay? And so this is a nut carcinoma, and you can see there's a little bit of necrosis here, but all the nuclei look about the same size. They're kind of round to oval. So that's quite a typical finding. It's not totally specific, but it's a clue, right? And you can see on higher power. And then the classic thing in nut carcinomas, because they're essentially a poorly differentiated squamous cell carcinoma, is abrupt squamous differentiation. So you can see this kind of carrot and pearl just appearing out of nowhere. Here's another one, like look at this abrupt squamous differentiation in this proven nut carcinoma. The antibody is very sensitive and very specific for this, and I highly recommend it when you need it. And I always kind of think, isn't this a bit nutty? The nut carcinoma is a challenging one, to be sure. I think I've ruled it out so many times over the years, so many more times than actually made the diagnosis. But it certainly occurs, and you need to very much think about it in the differential. Okay, and then olfactory neuroblastoma. Olfactory neuroblastoma has a lot of clues. One of the most helpful when you have it is this so-called dumbbell pattern on cross-sectional imaging. You can see this tumor that is on both sides of the skull base, right at the olfactory plate and the superior nasal cavity. And so it pinches in here and then bulges out on each side. That's a so-called dumbbell pattern, and that's a very helpful imaging pattern if the patient has a tumor this big and it's showing that. Not totally specific, but it's certainly helpful, as olfactory neuroblastomas happen at the superior nasal cavity. Now, histologically, even though they're not carcinomas, they are some of the most tightly nested tumors you will ever see in their well-differentiated forms and their lower grade forms. And this is a good example of that, where you can see these very tightly nested large collections of cells. The nuclei are pretty round and monotonous. Dystrophic calcification is another clue that olfactory neuroblastoma likes to get. Here's a different example with dystrophic calcification, a lot of neuropil. See this fibrillary stroma and these tight nests here of tumor cells. Again, the nuclei are round to oval and pretty bland. This is a pretty low grade, kind of well differentiated olfactory neuroblastoma. And then again, that nice fibrillary neuropil, which is a very, very typical of these. Now, sometimes you'll get to see the chromatin a little bit better. They are kind of neuroendocrine, so they often look speckled. I think they often look like carcinoid nuclei in the better differentiated ones. And then you can see this beautiful fibrillary stroma in the background. Olfactory neuroblastoma gets other features. It can have glandular differentiation focally, although that's certainly not specific and probably more confusing than helpful to get to the diagnosis. But you'll often see these homerite pseudorosettes. And then the last thing I'll say is kind of something that's being sussed out a little bit just in the past few years, is the so-called entity called olfactory carcinoma, where it kind of is in between high-grade neuroendocrine carcinoma and high-grade olfactory neuroblastoma. I'm not going to go into that a lot because the features are not that totally specific, but just to be aware of it. And these are some nice references for you if you want to read about it a little bit more and see what's being kind of thought of and proposed in the field. Okay, then we get to the S in nose alarm, and there's a lot of S's in the nose alarm differential diagnosis. Squamous cell carcinoma, obviously the most common. And these, many of them, most of them probably in the sinonasal tract, are non-keratinizing, but a lot of them are classic keratinizing squamous cell. I'm not going to show keratinizing squamous cell because we can all recognize it. But non-keratinizing tends to get these very big nests, okay, with very smooth borders to them. They don't tend to have a lot of desmoplastic stroma, so they really channel oropharyngeal squamous cell carcinoma in that way. They often have surface growth, so they have this kind of almost papillary ribbony surface growth, and even the invasive stuff will be kind of pushing or ribbony. And here's another example that's very, very exophytic and a lot of superficial surface growth with papillary growth. And non-keratinizing squamous cell it'll give you this clefting a little bit sometimes. And here you can see a little bit of squamous differentiation. Usually has a lot of apoptosis, mitosis. And then finally, if you get a little bit of spindling or fusiform growth where they get kind of pointy like this, that's pretty good for squamous cell. And of course, a little bit of a abortive early squamous differentiation there. So those are pretty much clues that you can recognize that even if it really doesn't show any maturing squamous differentiation, that large nests, a little bit of spindling, high mitotic activity, and lack of desmoplastic stroma are all very good clues for that. Now, we've got our SMARCB1 and SMARCA4 deficient sinonasal carcinomas, and this has really been established in recent years as a distinct entity, although it has different types of morphologic appearances. The the most typical appearance is as a basaloid carcinoma. Okay, so it will kind of look a little bit like a squamous cell, like a non-keratinizing or basaloid squamous cell. This is a good example of one of those. Okay, here the nuclei may be a little bit more round, but this is a basaloid carcinoma. So this is not really going to tell you that this is SMARCB1 deficient. But if you look closely in and around those nests, and particularly where the cells separate from each other, where either they're artifactually pulling apart or not, but or it's part of the tumor, you'll see this kind of rhabdoid or plasmacytoid look with a prominent nucleolus and eccentric cytoplasm. And that's a clue kind of in a basaloid carcinoma that then shows these areas that it may be SMARCB1 deficient sinonasal carcinoma. And then a subset of them, maybe a third of them, quarter of them are actually all these plasmacytoid or rhabdoid cells. And this is an example of one of those where it's just sheets and large nests of these cells with eccentric cytoplasm, pink cytoplasm, and round nuclei with prominent nucleoli. Here it is on a little bit higher power. And that's very, very characteristic of this and recognizable when you do run into these. Okay, now SMARCA4 deficient, and the protein for SMARCB1 is INI1, as I mentioned already, so the immunostain. Now, SMARCA4 deficient sinonasal carcinoma is even more rare. It's been reported in the past several years, particularly Abbas Agaimi has reported on this and others, but these are pretty uncommon, and when they occur, they typically tend to be a very high-grade carcinoma that looks almost like a neuroendocrine carcinoma. And this is a picture from one of those review articles and published articles on this. And if it kind of looks like a neuroendocrine carcinoma, but it doesn't really pan out with your immunos and other features, be very careful and think about applying BERG1 immunohistochemistry, which is the protein for that gene. Here's another few examples. Sometimes they can have rosettes and have this nested but kind of neuroendocrine look to them. The other feature that they sometimes adorn is they'll get these really ugly rhabdoid cells. And here's an example of one that's just sheets of these rhabdoid cells with very high-grade nuclei. And occasionally they'll be almost all those type of cells in the sinonasal tract. So that's a clue also when you have these rhabdoid cells. And I think if you see any of these features, you know, the smartest thing you can do is make sure you include INI1 and BRG1 in your immunostaining panel. Okay. SNUC, diagnosis of exclusion. It still occurs, and we still need to think about it. And there are some distinct features to it, but it doesn't have really any very specific markers otherwise. So how do we get to a diagnosis of SNUC and what clues on the H&E? Well, to me, the biggest is that it's sort of nested, but the nests are not very well formed or very tight. So here's an example of that. You can see the cells are sticking together, but just not very well formed or organized. We don't see any ducts. We don't see any squamous differentiation. We don't see any glands. And the nuclei here have prominent nucleoli and vesicular chromatin, and they're all about the same size. They have high NC ratios, but they still have just a little bit of cytoplasm. So on high power, you can see these prominent nucleoli, a little bit of cytoplasm, and no obvious differentiation. And here's another example. And the cells tend to fall apart a little bit from each other, very high NC ratio, but they're all kind of round nuclei, and they all are about the same size. And that's a good clue for SNUC. If you see a slightly nested tumor where the nuclei are all about the same size and an overtly malignant neoplasm, that's good evidence that it's probably a sinonasal undifferentiated carcinoma. Okay. All right, now small cell carcinoma, just like we see in larynx, just like we see in lung, the features are very similar in the sinonasal tract. If you kind of see sheets of ugly hyperchromatic cells, particularly if there's a lot of necrosis, again, these very hyperchromatic, kind of angulated cells where they're not really round, but they're also not like perfectly spindled. They're just kind of a little bit angulated. And then we look for nuclear molding. So there's a little bit of nuclear molding here as well, apoptosis, mitosis. And then I think probably the most specific thing that I see is teardrops. So if you see these kind of teardrop nuclei where they come to kind of a point on one end, there's a good example there, a couple of good examples there. Teardrop cells are a really good clue for small cell carcinoma. This one's a little bit more nested, but you can see the nuclear molding really well here. The nuclei are really shaping themselves to each other. So that's a good clue. And then finally, you'll often see crush artifact, you'll see necrosis, apoptosis, and for some reason, they like to get this really, really vascular stroma with really prominent endothelial cells. Look at these big vascular structures in the background, and that's kind of a soft clue for small cell carcinoma. Ewing sarcoma certainly happens in the sinonasal tract. In its classic form, it's a translocation-driven tumor. Usually it's sheets and large collections of relatively monomorphic cells. Here's a good example of that. And the chromatin here is kind of loose, and all the cells are kind of round to oval and all pretty similar in size. They don't look particularly pleomorphic. They look kind of clonal, if you will, or like a translocation-driven tumor. And if you get a little bit of clear cytoplasm, that's a good clue as well. And for us, I think the most important entity in the differential diagnosis not to miss, and that we found out in recent years by a number of people publishing on this, is adamantinoma-like Ewing sarcoma, where it actually looks like and manifests as a basaloid, almost a basaloid carcinoma. And this is a nice example of one of those tumors. Look at these really tight nests, right? Discrete nests. You get this maybe suggestion of a little bit of palisading in there. Nuclei are all about the same size as each other, maybe a rosette-like structure. Okay, again, all the nuclei are very similar, a lot of mitosis, apoptosis, a little bit of kind of a suggestion of palisading. And this is from one of the papers by Justin Bishop, where you can see some palisading, sometimes these little sort of hyaline-filled rosette-like structures in there, sometimes a little bit of hyaline stromal material in there. And again, the nuclei are all about the same size with relatively open chromatin. So some clues. Ewing sarcoma is one of those where you don't want to miss it. If you don't think of it and don't include it in your differential, don't stain for it, you're going to miss the rare cases when it pops up on your microscope and in your queue. Okay, so moving on to the A in nose alarm, the first A. So adenoid cystic carcinoma. And I love talking about adenoid cystic carcinoma because it has such beautiful morphologic features. Now, we can all recognize it in its classic form, right? Like cribriform adenoid cystic carcinoma with this basement membrane material, basophilic material filling in there, very tight cribriform. That's not really what we're talking about in the sort of blue cell tumor differential diagnosis. And here's grade 1 or tubular adenoid cystic carcinoma, also very distinct with these multi-layered tubules lined by dark hyperchromatic cells. That is almost pathognomonic of adenoid cystic carcinoma when you see it, but it's an unusual to see it mostly be just tubular. You usually see some cribriform in there. And then the difficult one is sort of grade 3 or solid adenoid cystic carcinoma. This is a patient with a large sort of inferior nasal cavity, maxillary bone, kind of hard palate bone disruptive tumor that they punch biopsied through the hard palate. And you can see this beautiful, very tight nest of very blue cells, right? And they get this kind of jigsaw puzzle pattern. So for adenoid cystic, that's a nice clue if the nests are pushing together. The other thing I like to compare this to is kind of like, cannonballs or large dark nests of very circumscribed tumor cells. Or you could compare them to like purple grapes. I have a friend and a colleague here, Matt Zarka at Mayo Clinic, who's a big wine aficionado. And so I put that in there for him, purple grapes, if it helps you think about these. Here's another example of solid adenoid cystic carcinoma with those very tight, dark, solid nests. And the way to recognize them as adenoid cystic is to look closely every once in a while in those presumably solid nests, you'll see a little bit of this basophilic material, okay, that is so characteristic. And sometimes you'll find better cribriform foci if you look around. But even if you don't, you often find this material in the mostly solid tumor, and that's a very good clue for adenoid cystic carcinoma. Now, lymphoma, I'm not a hematopathologist, but we tend to see a lot of lymphomas when they arise outside of nodes and outside of bone marrow, right? We get the extranodal ones in the head and neck. Um, and mostly it's going to be diffuse large B-cell lymphoma, okay? This is an example of that. Sheets of blue cells, lots of apoptosis, mitosis, and then they tend to have multiple chromocenters, okay? So they have dark chromatin, but it's kind of clumpy and usually one prominent nucleolus or multiple chromocenters. And then the other really specific clue is how they dissect in and around collagen and fat and other structures without really any stromal fibrosis. And here's an example of a large diffuse large B-cell lymphoma just infiltrating through the fat. Here's another example. See this? And you can see it dissecting around the serum mucinous glands without the stromal fibrosis. And that's sort of a nice soft clue of a diffuse large B-cell lymphoma. And then if we see an NKT cell lymphoma, you see a polymorphous background. Usually there's a lot of eosinophils, plasma cells, histiocytes, but we talk about angiocentrism. So if it's sort of angiocentric in distribution, that's a nice clue as well of possible lymphoma. Okay. Now, lymphoepithelial carcinoma is rare as a primary sinonasal tract tumor. It's obviously common in the nasopharynx, but that's a different anatomic compartment. And I'll just show one image of that, but basically it looks just like nasopharyngeal carcinoma that you see, but it's just arising in the sinonasal tract. It's clearly in the nasal, paranasal sinus or in the nasal cavity. And so lymphoplasmacytic infiltrate, and here you can see these sort of poorly defined collections of tumor cells, ill-defined cell borders, vesicular chromatin with prominent nucleoli, and this kind of, I call it a drunk pattern, where some of the nuclei are touching and some are far apart from each other. They look very disorganized. So that's a very classic lymphoepithelial carcinoma pattern, and that really should prompt you for EBV testing if you see that in the sinonasal tract. Okay. And then as we finally get to the last few letters in nasal arm, we get to alveolar rhabdomyosarcoma. Okay. And this is really, really an important one in the differential diagnosis, and one that can trick you, so to speak, and you can miss if you don't think about it. And the other thing that makes me think about as I look at AR is I think about this might be a pirate's favorite tumor, you know, AR. It's an alveolar rhabdomyosarcoma. Anyway, okay, so I'm going to stop doing pirate imitations and we'll get to the pathology. The other funny thing about it is ARMS. That's the abbreviation is ARMS, which is kind of conjures something else in mind. But anyway, so what are the few distinct features that can be clues to alveolar rhabdomyosarcoma off the H&Es? Well, they're blue cell tumor here. And it's sort of nested, but not really nested. It's a little bit, here's some more single cells. So if it's kind of sticking together a little bit, but not tightly, that's a clue. And then this myxoid stroma. They like to get this myxoid stroma in the background, okay? And if you do get to see some alveolar growth, and a lot of alveolar rhabdomyosarcomas in the sinonasal tract do not show alveolar growth for whatever reason. They tend to be more solid. But if you get some alveolar growth, that's good, where the cells are falling apart, mimicking a lung alveolus. And then if you get to see in there a little bit of eccentric eosinophilic cytoplasm, and particularly if you get this sort of abortive myotubule pattern here, where you get peripheral nuclei, right? These are starting to make myotubules. It's a really good clue for alveolar rhabdomyosarcoma. We often don't see that, but it's nice when you do have it. And then finally, really good rhabdomyoblasts and strap cells. Sometimes you'll see strap cells with actual striations in them. But again, that's not particularly common, particularly because we get small biopsies of these things and not the whole tumor. So melanoma, we're all the way to the end of nasal arm here. Melanoma has also got a lot of distinct features when it happens in the head and neck and other sites. It tends to also form kind of sheets and nodules of tumor, not discretely nested usually. A lot of single cells here. And then the cells often fall apart. Melanoma cells are not known to stick to each other, right? So when you make a big tumor mass full of them, they tend to fall apart from each other so they can kind of mimic alveolar rhabdomyosarcoma in that way. And so you can see here these cells kind of falling apart from each other. They have a little more cytoplasm than you might see in alveolar rhabdomyosarcoma, and the chromatin may be a little bit more open here. If you get prominent nucleoli, vesicular chromatin, and really prominent, particularly cherry red nucleoli, that's a really good clue for melanoma. And the other thing is they love to get these rhabdoid cells, okay? So similar to what we've seen in some other tumors, but tend to be uglier rhabdoid cells, but there's certainly overlap. But you can see these kind of eccentric nuclei, prominent nucleoli. And then finally, pigment. If you have a really pigmented one like this, well, that's pretty obvious. And I don't really think about that so much as a blue cell tumor differential, but occasionally you'll just have a little bit of pigment. Okay. So if you're looking closely, you see big nucleoli like this. Look at this huge cherry red nucleolus, and look for this wispy kind of uh, pigment. That pretty much can cinch the diagnosis for you. Okay. And then another very specific thing when you have it is pagetoid spread. Okay, here's lovely pagetoid spread in the surface epithelium of this melanoma patient, highlighted nicely by MART1 immunohistochemistry. Now, this is not totally specific for melanoma either. SMARCB1 deficient sinonasal carcinomas can give you pagetoid spread. So both of those should be thought of if you see this pattern. And then one of my very favorite tumors in the sinonasal tract is HPV-associated multiphenotypic sinonasal carcinoma. Here's an example of that. And then distinct features about that are that it tends to look kind of like adenoid cystic carcinoma. The very first name for it was adenoid cystic-like sinonasal carcinoma, HPV related. And here's an example. So mostly solid nests, but you can see these kind of tubules or ducts here. Okay. There's a little bit higher power, and you can see these kind of nondescript solid nests, tightly nested. And then again, here's this sort of duct-like structures here, maybe a little bit of mucinous material. Here's another area of one, and it looks really like adenoid cystic carcinoma here, right? With these big cribriform arrays with basophilic material in there. So anytime I have a sinonasal tract tumor that looks like adenoid cystic carcinoma, I always think about this entity as well. Again, here's solid, but you can see this tubular or ductal differentiation. And then I immediately go look at the surface. And if I can see squamous dysplasia or squamous cell carcinoma in situ over the surface, that's really helpful for multiphenotypic sinonasal carcinoma instead of adenoid cystic. And here you can see the basaloid cells kind of falling off of this dysplastic squamous surface. Here's another one where you can see some neutrophils in it, but there's a mitosis. This is actually dysplastic squamous epithelium on the surface, a very nice feature to clue you in that this is actually HPV-related multiphenotypic sinonasal carcinoma. And then this is just I've shown this figure so many times over the years from Justin Bishop in that series of 49 patients in follow-up that shows several different patterns of this squamous dysplastic epithelium that you see in these patients. What I find interesting is how variable it is, and some of them have a lot of pink cytoplasm and just random big cells. And this one to me is interesting. It looks almost like unicystic ameloblastoma or something. It really is kind of an interesting pattern. But usually these are going to stain for HPV and have transcriptionally active HPV, just like the tumor itself. But again, that's the most specific feature in a blue cell tumor if you see that squamous dysplasia and some adenoid cystic-like features that you're dealing with that entity. And then I will mention metastasis. So I'm not going to show examples of metastasis, but you need to be really attuned to the patient's history, and particularly if you've got a funny looking blue cell tumor in the sinonasal tract. Every once in a while, it's the presenting site of a occult malignancy somewhere else that's manifesting as a metastasis to the sinonasal tract. So keep it in mind, okay? And compare with prior specimens if you have them in the history. Now, a few notes about immunohistochemistry in this differential diagnosis, and then I want to go through just a few examples and we'll work them up from the H&E whole slide images. Things to be careful with. So cytokeratin. So I put an exclamation point here. For cytokeratin, for carcinomas, you really want extensive cytokeratin staining. So like this is a SMARCB1 deficient sinonasal carcinoma and cytokeratin A1, A3, right? It's strong and extensive. You have to be very careful with focal cytokeratin staining, okay? That happens in certain, if you're calling a carcinoma, you need to be very careful with focal cytokeratin immunohistochemistry. The other thing is neuroendocrine differentiation and neuroendocrine markers. INSM1 is a really nice marker that's emerged in the past several years. It's a transcription factor, so it's nuclear staining, but I think you have to have some caution with it. It's not as specific as we kind of thought when it first came out. And I guess that's the way it goes with a lot of immunohistochemical markers is they come out and the early papers suggest a lot of specificity and then people find the exceptions. Now it's still pretty darn good, but I don't use it alone. Okay, I always need good morphology. I'd like to have extensive staining for it, and I really like to see multiple markers positive. I still find synaptophysin and chromogranin and those together really best. So I just be careful with INSM1 alone, because every once in a while you'll find a tumor that's positive for just that, that isn't really a neuroendocrine carcinoma. Okay, now those are some of the features that I use to try to modify the panel. And I thought it'd just be useful to just go through 3 example patients from their whole slide images and history and kind of show you how I would work them up. So this first patient 1, a 57-year-old male, and he presented with a lower nasal cavity mass. And this is his radiology cross-sectional CT scan. And you can see this large tumor kind of eating through his nasal septum. Okay. So obviously, malignant looking pattern. And so here's the whole slide image of his tumor. Okay. And so like these patients, we almost always get kind of fragmented biopsies, right? Sometimes we get more tumor and sometimes we don't get very much. This one, at least we have quite a generous specimen. And you can see on low power, of course, a blue cell tumor. And you start to see the nests, very low power. You can see these really big, really circumscribed nests, maybe a little bit of clefting here, okay? And as you get on higher power in here, again, you see that clefting, the circumscription, the lack of stromal desmoplasia. And then a little bit higher power, the cells start to be a little bit oval, maybe a little bit fusiform. And there's kind of this suggestion even in here, maybe some eosinophilic cytoplasm, perhaps some squamous differentiation. And then higher power even, you can see mitotic activity is 1, 2, 3, 4. There's a lot of mitotic activity. There's no necrosis, but this thing is really zipping along. But again, here it gets almost a little bit spindly. So we've got a basaloid carcinoma, so tightly nested, that may have some squamous differentiation, and that's kind of it, okay? There's a little bit there, okay? So what do we do with that? Well, we kind of go back to our basic immunostain panel and say, what do we do all this, or how do we modify it? And so I think in something like this, I think you can safely get rid of CD45. I have a high threshold for getting rid of SOX10, but this is such a tightly nested thing that I really don't think it's going to be melanoma. That you could probably drop that off of there. I think I would probably add a P16 because this looks like it should be a squamous cell carcinoma, might have squamous differentiation. I think the other thing I do up front is a nut, although the spindliness doesn't really suggest it all that much, but there is maybe some abortive squamous differentiation or abrupt in there. Okay, so that's what I would do. I'd probably keep everything else, and we can talk about when and why. as we move along. And so the results in this patient are the cytokeratin was diffusely positive, P40 was diffusely positive, P16 was diffusely positive, and INI1 was retained. NUT was negative, Desmond negative, synaptophysin CD99 negative. And so this is the P16. And then a follow-up stain to that, of course, is high-risk HPV RNA in situ hybridization, which was strongly and extensively positive. Okay, and so this is an HPV-associated squamous cell carcinoma, non-keratinizing type. Okay, and it gives me just a quick tangent or side off of the diagnostic part is to talk about sinonasal squamous cell carcinoma and the fact that in recent years it's been pretty well shown that like a quarter of these patients have HPV-associated cancers. Okay, and this is a kind of a meta-analysis across 60 studies that Dan Faden did a few years ago. And it shows a couple interesting things. First, most of them are ethmoid sinus and nasal cavity, and that fits well for pharyngeal reflux of the HPV into the posterior sinonasal tract. So that supports how the HPV gets there. And then in their literature and other literature here in the US, at least, we have like at least 1 in 4 squamous cell carcinomas of the sinonasal tract are HPV associated. And across those many studies, the hazard ratio for overall survival and disease-specific survival it's something like 0.5, okay, which is statistically significantly significant. The data really suggests that these patients with HPV-associated sinonasal squamous cell carcinoma have a better prognosis. So it, as I always say, and I published on this, it makes the sinonasal tract kind of a hot spot for HPV-associated squamous cell carcinoma. And our new revised CAP guidelines for HPV testing in head and neck carcinomas is under review currently, but in that, we do now recommend that you do test routinely these patients with sinonasal squamous cell carcinoma for high-risk HPV, okay? And how to do that? Well, we really prefer and recommend testing directly for transcriptionally active high-risk HPV by RNA in situ hybridization, or an acceptable approach alternatively is you can screen with P16, and if you use that 70% nuclear and cytoplasmic cutoff, and then you have to follow that by HPV-specific testing if it's P16 positive, okay? And I think over time, the management of these patients is going to follow, I think, hopefully in time, as we start to test for them routinely. One warning is it's got to be pure squamous cell carcinoma, okay? Lots of things can have squamous differentiation in the sinonasal tract that actually aren't truly squamous cell carcinoma, so you have to be careful with that. Okay, so the second patient, patient 2, is a 31-year-old male with a large nasal cavity mass that invades the orbit with associated cervical adenopathy. An FNA of the cervical node was called malignant, and they were suspicious for metastatic carcinoma. So the operating diagnosis for this patient is a carcinoma of the sinonasal tract. On CT scan imaging, you can see another bone destructive tumor here in the left part of the nasal cavity in this patient. So if we go to the whole slide image, you can see here we've got a much smaller biopsy specimen, okay? So just little pieces here, a little piece. And on first glance, you kind of look at it and say, whoa, that's just a blue tumor. It's pretty nondescript. It's infiltrating in and around bone with some reactive bone formation. This does not look like it's going to give me very many clues. But if you look closely a little bit more, you'll notice that it's nested, but they're very kind of loosely nested, not very tightly so. There's myxoid stroma in the background. And if you go on kind of higher power, you get a sense that there's a little bit of cytoplasm to them. The nuclei are kind of angulated and not particularly round. And if you kind of look around a little bit more, you might maybe get a suggestion of, as the cells are kind of in here, maybe a suggestion of multinucleation in some of these cells like this, but not great. And that's kind of it. There's no pigment. There's no squamous differentiation. The nuclei are not particularly stippled looking. They're more just hyperchromatic. Okay. So this could be a number of different things, but certainly those entities that we have where the nesting occurs, but it's not very tightly nested, it's more sheet-like, should certainly enter our differential diagnosis as we think about this. Now, if we come to our starting panel and we think about what we would do in this, we could just leave it, right, and just start there if there's not really great morphologic clues. But I have a few senses, a little bit of a sense about what this could be. But I think it's a little bit maybe eccentric nuclei. I think I probably would add a BRG1 up front in this, but probably I just leave the panel as it is like this and go forward because it's not particularly giving us a lot of clues on the H&E. Now, the results, so it was keratin negative, P40 negative, SOX10, CD99, and CD45 were all negative. BRG1 and INI1 were retained, and it's synaptophysin positive and Desmond positive, okay? So follow-up testing, I think obviously if it's Desmond positive, keratin negative, you really should be cooking down the line of alveolar rhabdomyosarcoma, and so follow-up MyoD1 positive and myogenin a little bit of positivity, but MyoD1 was more extensively positive. Now, I'm going to tell you what was done instead, though, because it was a potential pitfall here. So the pathologist who initially had this case did 6 immunostains, not including Desmond, okay, and including INSM1. And what happened is it came back, it was synaptophysin positive and negative for everything else. And so the pathologist came to me to show me the case. And I said, oh man, you better order some additional stains. And so I said, why don't you get, cytokeratin Oscar, which we use a lot at Mayo Clinic, a BRG1, although this negative A1, A3 makes that pretty unlikely, but just to be careful with it. And then get a Desmond. And so it came back positive, retained BRG1, negative for Oscar cytokeratin, and positive for Desmond. Okay. And so then we got the myogenin and MyoD1 that were positive. So in theory, right, you could have gone back and you could have said, well, I'm here. Am I dealing with olfactory neuroblastoma or a high-grade neuroendocrine carcinoma that doesn't have keratin reactivity or has limited keratin reactivity? So you have to be very careful not to forget to throw your Desmond on these patients. We'll talk about that a little bit at the end. But FOXO1 FISH was sent. I always send that on these patients. And it was break apart positive. So this is alveolar rhabdomyosarcoma. And even the FNA of the neck lymph node had thought it was going to be a carcinoma. So another potential pitfall. Okay, last one, and then we'll do a few things to kind of talk about a few odds and ends here at the end. So the third patient, patient number 3, a 79-year-old female with a large destructive mass of the nasal cavity and maxillary sinus that invades the skull base. So like a very malignant sounding clinical history. And this is some imaging in that patient. You can see this large mass destroying the lateral wall of the nasal cavity and extending all the way up to the skull base and kind of pushing on the orbit. So aggressive radiology. So we're dealing with a malignancy, almost certainly from that imaging. And then we look at our biopsy specimen, okay? And so we've got lots of fragments. There's a little bit of fibrous tissue, and then we see these kind of large collections of tumor. We'll come back to the circle in a second. So we see these kind of collections of tumor. We don't have much stroma here, so that doesn't really help us to get the interface with the stroma, but it does give us a sense of how to look at the individual tumor cells. And we can see they're kind of round oval, irregular nuclei, okay, and they have some of them have eosinophilic cytoplasm. So it's not such a total small round blue cell tumor because they do have some cytoplasm, okay? Some of them are a little bit fusiform, maybe even a little bit spindly. Let me see if I can find another area here. Let's go on this area. Here you go. So eosinophilic cytoplasm, there's some prominent nucleoli here and here and here, okay? And they have this, again, a little bit of a rhabdoid or eccentric cytoplasm where they're kind of falling apart. And I think they're kind of polygonal here, and you kind of go down here and they get a little bit maybe spindly or fusiform. So anytime I see something that looks maybe spindly and epithelioid or polygonal, I'm always worried about melanoma. Okay. And so other clues. Well, if I'm worried about melanoma, I always try to go and look for pigment if I can find pigment anywhere. And very, very focally in this tumor, there's maybe a little bit of a suggestion of some pigment here. I think there was a little bit right there, just a very little bit. And some of these big, uglier multinucleated cells. But you can see here's a big, huge nucleolus there. So some clues that this might be melanoma, but again, that might be hemosiderin. You can't tell for sure. It's not like obviously pigment. Um, but so those are some of the clues that we had on the H&E. And then if we go to our kind of basic panel here, this is where I would say, well, I'm kind of worried about melanoma, and if I'm very, kind of suspicious of it up front, but I don't think it's definitive off the H&E, then I think adding, S100 melan or other differentiation specific markers for melanoma up front makes sense. And it turned out in this patient that they had melan A positive, S100 positive, SOX10 positive tumor with INI1 retained, negative for these other markers. And then actually there was keratin positivity, not insignificant in this patient, which was a little bit confusing, but all these differentiation specific markers for melanoma really cinch the diagnosis. So this is a mucosal malignant melanoma. So in these last maybe couple of minutes, let's go through and talk about some other potential pitfalls. I don't know about you, but I'm old enough to remember playing Pitfall on my Atari years ago, and I love that game. But let's try to swing over the alligators and not land on top of them. So a couple of things. S100 and melanoma. S100 is a good marker of melanoma in general. But as he's published so much in head and neck pathology, in particular sinonasal tract pathology, Justin Bishop and some others have published recently on a series of sinonasal malignant mucosal melanomas where S100 was either negative or only focally positive. So be careful if that's your only marker. I tend to like SOX10 better for screening. But the warning with SOX10 is it lacks some specificity, like basaloid squamous cell can be positive and some salivary gland entities and other things can be positive. So you've got to follow up SOX10 with more specific differentiation markers if it's your only positive test. So it's really good for screening. So it's good in that initial panel, but you have to be careful with it alone. And then cytokeratins. Oh man, there's a lot of cytokeratins. I mean, a lot of cytokeratins. And it's hard to remember, which ones stain what entities and which are high molecular weight, low molecular weight, what's in there, in the different cocktails and covered. It's kind of hard to keep up with mentally, honestly. We as head and neck pathologists tend to remember that CK56 and 34 beta E12 are high molecular weight, tend to stain squamous things. But it's hard to do that beyond there. And you really have to be careful, as I mentioned, with focal keratin expression. Okay, A1A3 is good. Cytokeratin Oscar is pretty good. I think you have to be careful with CAM 5.2. It tends to be the most promiscuous of the keratins and will stain a number of things that aren't carcinoma more than the other ones. So I usually don't use that one in this differential diagnosis, but just be careful. Now, aberrant cytokeratin expression, at least 25%, maybe a third, 30, 40% of olfactory neuroblastomas can show focal cytokeratin expression. Now, of course, it's expected in the olfactory carcinoma category, but there it's going to be extensive and you're going to have other clues to help guide you. But in typical olfactory neuroblastoma, you can get some keratin expression. Alveolar rhabdomyosarcoma and melanoma are well known that they can focally and occasionally have cytokeratin expression. It's a known pitfall. And again, it's a reason to use a multi-marker panel approach when you're working these patients up. And then CD56. Where do I even start with CD56? Maybe we should just say, don't even get me started on CD56. It is not a good neuroendocrine marker. It's not specific. I just think it'll be more confusing than helpful. I don't order it at all, and I do not recommend using it in this differential diagnosis. And then INSM1, I'll impugn INSM1 a little bit more here. This is a HPV-associated oropharyngeal squamous cell carcinoma that was diffusely P40 positive through all these regions, and you can see INSM1 is not even that focally positive. It's a lot positive. The other neuroendocrine markers were negative. So occasionally you'll see cancers do this that aren't truly neuroendocrine carcinomas. So you need a panel approach with immunohistochemistry for neuroendocrine markers. Okay. You really want to see other markers be positive and have the morphology be really suggestive when you're using that as well. Omission of Desmond for alveolar rhabdomyosarcoma and CD99 or NKX2.2 for Ewing sarcoma. Never do this. I just never omit them anymore. They're always in my first round of stains. It's safer. You'll sleep better at night. You'll catch it when it is that rare tumor that's mimicking something else in the differential diagnosis. D for do not omit. I just don't omit Desmond and a Ewing's marker in my initial panel. And then finally, P16. P16, I love P16. It's very helpful and very useful as a surrogate of high-risk HPV and useful in occasional other scenarios and settings, but I always kind of liken it to a chainsaw. A chainsaw is a very powerful tool that can do some amazing things if used correctly. And if you use it incorrectly, it can be kind of dangerous, a dangerous tool. So P16 is a little bit like that. I see P16 thrown at so many different things in surgical pathology, but I think you really should stick with when you're trying to cook down the line of an HPV-associated tumor, okay? So be very careful with it. And then at the end here, I would say the pitfalls really do await. These are some dangerous, difficult specimens. And so before signing these out, I would say, always try to ask yourself, what else could this be? Particularly if it doesn't line up perfectly for a certain entity, what else could this be? I go back and I reread the differential diagnosis. I literally open the document and look at the differential diagnosis entities in the nose alarm. And show colleagues, share these cases. I think that can be very, very important and very helpful to do. Because you can't diagnose what you don't think of, right? If you don't think of something, you're never going to be able to make that diagnosis, and that's where you can potentially make a mistake. So the next time you have one of these biopsies of a sinonasal malignancy, and it's a blue cell tumor, I hope that you will potentially find this helpful and think of it through the kind of nose alarm differential diagnosis. And that instead of feeling exasperated and worried about it, that you might feel more relieved and you think to yourself, oh, no problem. I've got this. I know what to do. I'll work through it in this way, and I will be able to get to the right diagnosis for my patient. And with that, I'd like to say thank you. And I think we'll open it up. It's time for a Q&A session. So again, thanks for your attention. This is outside of the Shea campus at Mayo Clinic, Arizona. This is actually a picture I took on my first day at work after I parked of the mountains behind there in the desert. It's really beautiful in the evenings. And thank you for the chance to do this pathcast. I hope that was helpful.
Thank you so much, Dr. Lewis. This was an amazing discussion in which you have covered all the components of the nose alarm. I think this is really good, and then the audience appreciated it. There are a few questions I can see online, so I will read them for you. And some of the questions you have probably answered later in the lecture, but still, one question that came in the very beginning was, has S100 officially made its exit from the initial panel? I think you explained it, but still you might elaborate on that.
I think so. I mean, I really feel like SOX10, if you're going to pick one marker, is a nuclear stain and it's very, very sensitive. So for me, I don't screen with S100. And, it like at my former institution, for some reason, S100 was it just didn't stain well in general. Uh, and so I was always a little leery of it, even just the way it worked in the laboratory. But even when it's staining well and you see it, across different tumor types as you kind of expect, there's again the recent publications and these occasional examples of sinonasal melanomas that can be S100 focal or negative. So again, I like SOX10 for that. And I give Justin Bishop full credit. I think this panel approach and that initial panel that I've modified a little bit was really something I learned from him years ago, and I really liked it a lot. And that was in the panel that he had recommended.
Right. Thank you. Staying with immunostain, there is another question from one of our viewers who says that I think how close are we to validating P16 as a surrogate marker in the sinonasal tract for HPV? Probably you answered that as well, but please, you might still elaborate. Thank you.
Sure. So P16 is a good surrogate in the oropharynx when in a location where you have a high incidence of HPV associated cancers, certainly the US and Canada, parts of Northern Europe, and using that strict 70% cutoff. When you get outside of the oropharynx and you get into areas where you have a low attributable fraction for HPV, so like larynx and oral cavity, where it's probably 3%, 5%. And again, those sites, we don't know prognostically what it means anyway, but you have to use HPV specific testing. You can't use P16 alone. So in the sinonasal tract, even in this highest incidence area of the world where we only have 1 in 4. Okay, so 1 in 4, if you use P16 alone, you're going to have, with that 70% cutoff, you're going to have a lot of false positives. Okay, too many. So you really need HPV specific testing. I like to actually go straight to HPV RNA in situ hybridization, but you can screen with P16. If it's negative, that's okay. It's a good, very, very sensitive marker of an HPV associated cancer. So a negative result, basically you can rule it out. But a positive, you have to follow up with HPV specific testing. Okay. And we highly recommend HPV RNA in situ hybridization if you have access to it.
Thank you. That specific question was actually asked by one of our colleagues from Netherlands, who, first of all, who compliments you for the lecture. And then the question was the same, like, why is there a preference for direct a high-risk HPV testing instead of first using P16 immunostain as a screening in sinonasal? I think you have answered that, right?
Yeah, it's okay. It's okay. I think either approach. I think it's always a challenge. You'd like to simplify things, and P16 just is complicated. I mean, it's a bit complicated. I still struggle with sometimes how I'm applying it and what to do with it. And I think partly that part of our recommendation as a committee this time around is to try to actually simplify it a bit if you go straight for the RNA in situ hybridization, because that's incredibly specific and sensitive. But yeah, you can screen with P16. Just don't use it alone.
Right. No, I think that's a good point, because in our practice here too, even though I do primarily GI pathology, and then in NL HPV related carcinomas, we have seen that if we just do P16 and then you say that it is HPV related, it's not always true. I mean, I had a case like where actually the HPV, in situ hybridization was negative, and it is known, right? So that's why it follows the same thing for sinonasal tract too. So yeah.
What's an anal squamous? If you took 100 anal squamous cell carcinoma patients, what fraction in the U.S. would be HPV associated? It's probably, is it half,
Right. I don't know
2/3?
the
I don't know,
exact number,
something
but
like that.
not
Yeah,
all.
yeah. At least in the head and neck, oropharynx, it's like 85, 90%, in the U.S. So, um, yeah. So I think when you start to get an attributable fraction that gets lower like that, then the surrogate marker part you have to be much more careful with it.
Right. So there is another question or a comment by one of our colleagues in India who says that you have been emphasizing on similar size nuclei in most of the blue cell tumors, but any lesion with dissimilar size nuclei, because he also insists that his experience with, I think, rhabdomyosarcoma with dissimilar nuclear size. What's your take on it?
Yeah, I know what you mean, and it's sort of that's where the blue cell tumors tend to look kind of look similar to each other. I mean, the ones where I really think about it, and none of these are absolute, but there's sinonasal undifferentiated carcinoma, usually alveolar rhabdomyosarcoma, Ewing sarcoma. Um, these all, tend to have similar nuclear size. Melanoma tends to vary more. Squamous cell tends to vary more. Um, the SMARC deficient carcinoma, use SMARCA4s tends to be a little bit uglier and more pleomorphic. But yeah, lower grade olfactory neuroblastoma tend to be very similar in size, but they all have exceptions. Those are probably not going to be your most helpful feature off the blue or off the H&E to try to tailor your differential diagnosis and your initial immunohistochemical workup.
There is another question, Dr.
Okay.
Lewis. Are there any difficulties in distinguishing HPV squamous cell carcinoma and HPV multiphenotypic sinonasal carcinoma, especially when no adenoid cystic-like areas and just the solid part?
Yeah, they can look similar. Now, one of the things we didn't get into, and I probably should have mentioned it, but we didn't have an example case. So if you think it could be HPV related or associated multiphenotypic carcinoma, I immediately look for that squamous differentiation on the surface. But the blue cell, often you don't have it. And the blue cell component of those tumors can look a little bit like a non-keratinizing squamous cell, but you're going to see ductal differentiation. Okay. These tumors have salivary gland-like differentiation. They're kind of, I think of them almost as like having like surface disease and also, salivary gland type differentiation in a combination. But you're usually going to see some tubular or ductal differentiation. And then you'd say, well, maybe it's adenosquamous carcinoma. You usually don't see good mucin production in multiphenotypic sinonasal carcinoma. It's more duct-like and ductal. But that's a differential diagnosis, and they're both going to have a lot of mitosis, apoptosis. But when you think it's HPV-associated multiphenotypic, in addition to HPV testing up front, you will do myoepithelial markers. So calponin, smooth muscle actin, the P40 or P63 will show abluminal staining. So you'll have some abluminal positivity, and you'll have around these ducts. In these ducts, you'll have that will be negative for P40, and you should find some degree of myoepithelial differentiation. Calponin's a really good marker for that. So it's the HPV associated pattern. It's the ductal differentiation and myoepithelial differentiation that all make that diagnosis. And that's obviously different than squamous cell, which was not going to have myoepithelial differentiation.
Next question is, do multiphenotypic and oropharyngeal carcinomas occur synchronously? And there is an additional question from our viewer that how do you prioritize ancillary testing with small limited biopsies that may need molecular?
Okay. Good. So HPV-associated cancers, there's not a lot of reports of like getting sinonasal HPV-associated carcinoma and like oropharyngeal squamous cell HPV-associated squamous cell carcinoma. It occasionally, like these are rare case reports, but it's not particularly common, but it does occur. I have not seen a report of HPV-associated multiphenotypic sinonasal carcinoma and synchronous like oropharyngeal or another HPV associated squamous cell carcinoma at a different site. There's no reason it couldn't happen, but I haven't seen it reported. Mostly, one of the differences that we do see is that most HPV-associated carcinomas in the oral pharynx and other sites in the head and neck are usually HPV-16. And at least the relatively limited data that we have is that HPV-associated sinonasal multiphenotypic carcinomas are much more often HPV-33 and not usually HPV-16. So maybe that's one reason that you don't see that many patients with synchronous primaries in other sites and the sinonasal tract that manifests as multiphenotypic in the sinonasal tract. I don't know. I'm doing speculating there, but
there was a second part of the question, a little bit unrelated, that how do you prioritize ancillary testing with limited biopsies that might need molecular?
Right. A few things like that's where using your eyeballs, on the H&E is really important because you can prioritize stains. Like there's always this tension between ordering all of the potential stains that you're going to need and getting them quickly versus taking a staged approach where you run a few and kind of start down the divisions in the diagnostic tree. And if we had more time and probably more pressure to do less immunostains, you could probably, I'm pretty thinking this is probably a carcinoma. I'm going to drop a pancytokeratin on it. And if it's strongly and diffusely positive, kind of proceed down that and avoid doing the other immunohistochemical stains that I might normally do in the initial panel. So it's kind of a balance between covering other entities and getting it done as quickly, in a relatively quick manner. Rather than taking several more days and doing it sort of in little rounds of immunostains. So if I have limited material, I really want to laser focus in on what I think it could be by limiting my immunostains up front. The other thing is I really try, if I've got multiple blocks, I try to stick with just staining one of those blocks and saving the other one for potential ancillary testing or molecular. And then the final thing is I order a lot of unstained slides when you order your initial panel. Order a lot of unstained slides so that if they're cutting the block, they don't go back and cut the block multiple different times because you can use those saved slides, work pretty well for molecular, but certainly for fish. So yeah, that's what I usually do.
Thank you. I think that's a very, very practical question and a very insightful answer. We face that all the time. I mean, if we exhaust that issue, we don't leave anything for probable molecular tests which are necessary.
Well, and these can be difficult, like sometimes you get into a lot of immunostains, right? Like you get deep in the panel because these are difficult to get to the diagnosis in these blue cell tumors. So you use a lot of material for stains in certain patients.
Another question, Dr. Lewis, how can one effectively differentiate between neuroendocrine carcinoma, olfactory carcinoma, and neuroendocrine carcinoma like IDH2 mutant carcinoma in terms of histopathology, immuno, and molecular?
Yeah. The challenges. Yeah. So I guess I'd start with, just run-of-the-mill or typical high-grade neuroendocrine carcinoma. I mean, it really ought to walk the walk and talk the talk, so to speak. I want it to look like and stain like I would see in another site. Particularly, we think about pulmonary pathology where you see those most often. Um, for that versus olfactory carcinoma, um, olfactory carcinoma, I really feel like we're, folks are onto something with that as maybe a distinct thing, but I don't think we have good diagnostic criteria for when it really is that or it's not that. Um, and but I will say that if it's an upper nasal cavity tumor, it looks like a high-grade neuroendocrine carcinoma, but it's a little more nested and tightly nested. Um, and particularly if it has sustentacular cell staining, uh, that's really a good clue to me that it is coming through or part of the spectrum of olfactory uh, malignancy. Also, if it has other markers that you might see in olfactory neuroblastoma, there's calretinin and the somatostatin receptor. There's some, I didn't get into them, but there's a lot of other kind of surrogates of olfactory neuroblastoma and olfactory kind of neoplasia that sometimes you have. Um, they often have a very vascular stroma in between, but that tight nesting is a good clue. If it looks like high-grade neuroendocrine carcinoma is really tightly nested, that may be olfactory carcinoma. IDH mutations are seen in I don't know, some subset of SNUC, sinonasal undifferentiated carcinomas, but haven't really emerged as it being a distinct entity, IDH1 mutant carcinoma. And you see it in some other tumors like that have neuroendocrine differentiation. You can see it in things that look like olfactory carcinoma, rarely. So I feel like the IDH mutation to me is not a distinct entity yet. And so we don't have a category in the Blue Book yet. And I think that's still under discussion. But I think, to tell it from olfactory carcinoma, I think you really need to use those features that I kind of talked about, those kind of clues and things that tend to point towards olfactory uh, carcinoma otherwise. I don't know if that answers the question that well.
Oh, no, I think that's great.
Difficult.
One last question, Dr. Lewis.
Mm-hmm.
How do you approach cases where immunoprofiles are overlapping in these blue cell tumors in the sinonasal tract? And an additional question is that what's the role of molecular testing in diagnosing sinonasal blue cell tumors, and has it improved any accuracy?
Mm-hmm. Yeah. So, and I guess the thing when you do a talk like this is to try, point out all the the times when the immunostains don't line up right, or you get aberrant staining in an entity that's not characteristic of it and might make you think it's something else. I mean, the classic thing is neuroendocrine marker staining and keratin staining in alveolar rhabdomyosarcoma. I think, I start with the H&E, and when the immunostains come back and they're funky, I go right back to the H&E and I look at it again, and I kind of reassess it with the new stain results in mind. And then I look at and think very closely about the markers that are positive and don't make sense together and what entities sometimes show that, and go back to those and then do a deeper marker examination with other markers that can kind of resolve that specifically. I know that's not a totally specific answer, but go back to the H&E, try to get some clues from it again, and then arbitrate it with markers that can help you tell them apart. And they almost always will help you resolve it. If there's, if you've got keratin in a melanoma, for example, well, a smart workup, you always have that melanoma marker in your panel, so you won't miss that as carcinoma, for example. But yeah, and doing additional markers of melanoma, additional markers for the possible carcinoma that it might be, to help you tell those apart. And then the molecular, So fish is very useful for these translocation nut carcinoma. Boy, that immunostain is really good. You almost never need fish. And the SMARC B1 and SMARC A4 deficient, the BERG1 and INI1 are really, really helpful. They work really, really well. When do you use fish? The biggest thing is alveolar rhabdomyosarcoma. Usually, even if you're very confident, I always close the loop with the molecular on that. Occasionally with solid adenoid cystic carcinoma, I didn't talk about MIB in situ hybridization, but there's some literature on that, and that can be useful if you have it available. But particularly, you can do fish, break apart fish for MIB in solid adenoid cystic carcinoma, and occasionally that really can save you in a very difficult case that's either squished or the morphology is not great, or you run out of other material to test, or it just doesn't quite line up as distinct from other entities on your immunohistochemical workup. Yeah, so, and then sequencing, fusion panel testing. Some people have a lot of access to fusion panel testing. And I think that can be extremely helpful some ways to rule out that it has a translocation in a common set of genes, or to cinch a diagnosis that you're suspicious of. I don't have a lot of access to that as a clinical test or use that much, but in just very select patients, it can be extremely helpful. Okay.
Thank you so much, Dr. Lewis. I think these were all the questions that I found online on Facebook and YouTube. And thanks for this excellent talk, Dr. Lewis, and answering all the questions from our viewers who are very appreciative. And you'll be happy to hear that we had a lot of viewers, I think over 100 who joined live from different countries, including Italy, India, Zimbabwe, Bangladesh, Saudi Arabia, South Africa, Australia, to name a few that I could keep track of. And thanks to all our viewers for your support, and thanks for listening. And you can always follow Pathcast and our lectures on our social media platforms, including Facebook, YouTube, Instagram, and also on X. And our next lecture is actually coming up on this Friday. So we will switch to our hematopathology lecture series, and our speaker will be Dr. Dennis O'Malley, who is a very renowned hematopathologist, and he's going to talk on IgG4 related lymphadenopathy. That's on November 22nd, this Friday, same time, 12 p.m. Eastern time and 9 a.m. Pacific time. So hope to see you all then. And thank you again, Dr. Lewis, and we hope to have you back. And there were a lot of viewers who appreciated, and they said that you are always great, and it's fun listening to you. So hope to have you back in future soon, Dr. Lewis.
Oh, well, Dr. Manan, thank you for doing this. The Pathcast is great, and it's been an honor and a pleasure. Thank you.
Thank you. Thanks a lot. Bye.
All right, everybody.